Oh, good afternoon. My name's Paul Mara. I'm the Managing Director of Quality Practice Accreditation and a rural general practitioner in the lovely town of Gundagai, New South Wales. Thank you for joining us for today's webinar in this Reimagining General Practice series. We're looking particularly today on the financing of general practice. The aim of this series is to promote discussion on the future of general practice as we attempt to use the leadership and lessons from the COVID-19 crisis to re-establish the role of general practice and address some of the long-term challenges that have faced us for many years. We've probably sleepwalked into this crisis. It's been too difficult for many or even most practices just to keep our heads above water. We have to manage what comes through the door on a day-to-day basis, and to engage in any significant strategic planning has just been, for many of us, just too difficult. Professor Simon Wilcox said recently, and it's worth repeating from our last webinar, decades of underinvestment in primary care have resulted in bugger all change in a system that's no longer fit for purpose. I believe it's time that we start to address this and use this COVID opportunity when people are willing for change to actually move forward. Now, the bottom line question that many GPs are asking is, where are we heading in this COVID world? And I say COVID world because I'm not sure we're really going to have a post-COVID world anymore. It's pretty obvious that this whole COVID scenario is going to have implications that go a long time into the distance. So before we get started, we'll have a disclaimer. The content of the presentation is copyright. We have found in the past that people often take what we're doing and take it outside and out of context. So we will stress this copyright. The comments could not be construed as personal, financial, or business advice. The issues raised are for discussion and to encourage debate. Practices will need to seek their own legal, accounting, or other professional advice before taking any action on any of the ideas presented. Well, before we really get started, I'd like to thank those who had the comments and feedback from our last webinar on how we pay our doctors. We always value your feedback and questions and welcome them during or after this presentation. It's probably worthwhile recapping because this leads into this new funding of general practice at the system level. I made a couple of points about how we engaged and paid our GPs, both about the engagement models that have evolved over many years, namely doctors working under management services or licensing contracts, and the potential negative impacts these contracts may have on quality care and a practice's ability to appropriately manage population health, preventive care, and chronic disease within a practice. I also said that in my opinion, these models were established or driven at least partly by the desire to protect the head organisation against medico legal claims and to reduce liability, and the costs associated with payroll tax. This payroll tax burden is one that affects us all. Other reasons, of course, for the model evolving include the general burdens of administering complexities of employment arrangements and red tape within general practices. There's also a strong desire by doctors to be seen or actually work independently. And that's not necessarily legally independently, but it's also professionally independently. And we've seen a great gender change in general practice and a desire for much more flexible working models and hours across the scene, not just in general practice, but right across society. Linked to how we engage our doctors is the remuneration model for many or most GPs based on a percentage of billings or receipts. I postulated that both of these models are supported or even driven by Medicare, but don't necessarily support medication care. We discussed these changes in relation to whether doctors are truly independent contractors or employees by another name. And I'd implore you, if you haven't done so yet, to have a look at the ATO and the state revenue bodies' websites and make sure that your contractors or employees actually fit the requirements. What I also said, the situation with general practice at the moment is like a canary in a mine, because we have very, very well managed companies that have signalled, even though they've got huge economies of scale, that they're not getting a decent return from general practice and that they're seeking to offload their practices. So the question then becomes is how can an average practice, a smaller practice, begin without those economies of scales, begin to cope, especially when there's strong competition for doctors and doctors are out there in the marketplace commanding ever increasing percentages because of this strong competition. So these engagement and remuneration models, while initially valued, are now seeing perverse incentives and adverse consequences creeping into the system. And we need to start thinking very strongly outside the prism of just fee-for-service underwritten by Medicare. Now, when I made these points, they seem to have struck a chord with many of the attendees from our last webinar. In fact, I was actually surprised at the level of agreement from webinar participants on the need for change and the recognition that the current remuneration and schedule and engagement models are simply not working. So reform in general practice cannot purely be seen through the prism of Medicare, and this is where we want to broaden out. I argued we need more flexible remuneration models in general practice that better meet the needs of patients, practices, GPs and the health system if general practice is to continue to remain relevant. But change is really, really difficult, as we're all aware. As Max Planck, the famous German physicist, said, truth does not triumph by convincing its opponents and making them see the light, but rather because its opponents eventually die and a new generation grows up that is familiar with it. So I just need to answer now a couple of the questions that came out of the previous webinar. First of all, in regard to the gap payments, I believe that we need to again discuss the role of gap payments and come up with a reasonable solution, looking at patients' out-of-pocket fees while protecting them from large medical expenses. This is one way in which we can start to restore the integrity and the financial viability of general practice. Politically, gap payments or attempts to introduce them have not met with much success. The problem, I believe, was primarily the attempts to make these compulsory instead of allowing the market to actually set the fee. So we have voluntary gap payments associated perhaps with bulk billing instead of making a compulsory gap payment. I suspect, however, that in many areas, practices would not be able to or feel they could sustain any gap payments, even if, for example, a co-payment was allowed for a bulk billed service. There was widespread agreement and comment from practice owners about the current percentage-based arrangements and service contracts. Many of the practices felt from their own perspective these were not sustainable. And there was a lot of interest in exploring the option of a fixed price contract or a cost plus management service fee arrangements, either at the practice level or using the internal organisation. So these are some of the comments that we got from the last webinar. With more and more GPs not wanting to take on the burdens of practice administration, I'm convinced that we will see many of these types of arrangements, these fixed price or cost plus management contracts, evolve. So today we'd like to move beyond how we pay our individual GPs and the engagement models to looking at a broader approach to the system and general practice funding sources, but perhaps that applies some of these thoughts or ideas at the general practice level, at your practice level. For most GPs working in practice, funding almost all comes from fee-for-service Medicare, the Practice Incentive Program and Practice Nurse Incentive Program, patient fees, some project or grant funding. This basically summarises it. Although there are some private fees and other arrangements, this summarises it for most of the general practices out there. Rural practices, however, have a much more diverse income source, with perhaps hospital-based payments based on a sessional fee-for-service or a grant or a combination, and procedural and other grants. So in rural practices, that income that reflects their job, and I'll discuss this more further, actually helps to provide a significant boost in overall income in many circumstances. These arrangements reflect what Professor Richard Murray calls the job, or the requirements of the work undertaken or performed. If a doctor is required to be on call, then an on-call payment could apply. Now, with Medicare, the payments don't often reflect the job. To give you some idea of the value of some of these incentives and an approach that we might seek to adopt down the track, it is illustrative to look at a few real-world examples. So New South Wales rural doctors under their rural doctor package are paid a weekly on-call rate of $2,100 for a full-time on-call. Now, ignoring the bulk billing incentives, this is equivalent to a Medicare rebate for 50 Level B consultations. So when you see that you can apply some of these block payments, it's actually quite significant in terms of the work that we're actually doing as general practitioners. Again, if we looked at doctors working in the modified Monash 5 level, if you look at the rural incentive then, they're annualised out at a full-time equivalent of around $21,000 that's paid annually. Well, this is a Level B equivalent of 520 consultations. I could go on, but the bottom line is that when rebates are squeezed, block payments or grants can often make a huge difference to the economic sustainability and indeed the capacity to provide better patient care and invest in practices. So by thinking differently, we can move beyond the prism of Medicare in addressing problems with the funding of our health system. It is often easier to negotiate or sell an argument for a considerable funding increase when the goal or outcome is obvious than to argue for an increase in an open-ended, non-specific rebate increase. So let's look at the income metrics in a general practice. So let's bring the system down to the general practice level. Under Medicare or any fee-for-service practice system, income before costs is dependent on three key metrics. The patient population, or the number of patients that you have captured, if you like, in your practice. The encounters per patient. That's the number of times each patient is seen in consultation in the surgery. And the fees that are generated per patient encounter. So these are the three metrics of income. Now, most practices intrinsically understand these metrics, but they cannot necessarily articulate or sometimes apply them in a planned or strategic fashion. If income is going up or going down, then a practice might try and attract more patients by offering more services or putting up some fancy signs or whatever you've seen practices do. They may take steps to increase patient turnover by recalling patients or declining to issue repeat scripts over the phone or giving out results over the phone. Now, telehealth and the COVID have changed this significantly, and it's going to be interesting to see what happens with these telehealth arrangements and with the increase in the bulk billing incentives when these actually lapse. Or practices may identify otherwise to increase fees per encounter. There are consultants in the market who promote themselves by helping practices identify so-called underutilised items from the schedule within various individual general practices. And related to this is the pressure that is seeing patients seeing less time being spent per patient for bulk billed services. So these are the metrics. This is the mathematics of an income. Now, it's interesting if you did this exercise, so try doing it, and see what a small increase, say 10%, in each of these metrics does to practice income in your practice. So increase your patient base by 10%, the number of times each patient is seen by 10%, and the income generated per encounter by 10%. And the impact on practice profit or income can be quite dramatic, especially as the increased costs associated with these small increases at each level would be negligible. However, if we look at a fully bulk bill practice, and in a sense with competition from other practices, the only way to increase income is to look at patient turnover and income generated per patient. Now, I would argue that this is ultimately a lose-lose-lose scenario. We've forced ourselves into a loss for the doctor, a loss for the practice, and a loss for the patient. And as one politician said to me last year, GPs are addicted to Medicare. They are caught in an activity trap because of the Medicare fee-for-service bulk billing system. So let's think outside the box when it comes to financial options for general practice. By thinking slightly differently, we can move beyond that prism of Medicare to address problems within the funding of our health system. So first of all, there are three areas that we'd like to look at under what we're calling a blended payment arrangements. And this term blended payment is going to become more and more in the vocabulary for practices. So first of all, for fee-for-service. The point to make is that fee-for-service medicine is not necessarily private medicine, and many people equate it with that, particularly when almost all the services are bulk billed. I mean, that's not private medicine, that's nationalisation by a different route. Just as George Orwell wrote, all animals are equal, but some are more equal than others, and at our last webinar, I noted that all practices are perfect, but some are more perfect than others. Almost all practices I talk to don't bulk bill. Will they only bulk bill pensioners and children? Will they limit bulk billing as much as they can? But overall, what we've seen is that bulk billing levels are over 80% and rising. The truth is that for many of us simply do not appreciate or know the level of bulk billing in our own practices. So fee-for-service shouldn't be equated with private medicine. To the extent that its majority of it's underwritten by Medicare, it works very well for acute management or patients with acute presentations. Medicare, in fact, was based on Mediscare, Mediscare, which was the campaign mounted prior to the election before last, was based on the idea that if rebates don't go up in general practice, then doctors would start charging their patients more. Because of the workforce paradox in general practice, we don't have enough doctors, but we have too many doctors, and an economic concept called price elasticity, this was never going to be the case for GPs. Practices simply have not increased their fees in response to the drop in rebates or the drop in real terms in rebates. It is simply easier for practices to crank the handle a little bit more than bear the pain of introducing private fees. You know, it comes to reason. If you tried to charge a patient even a very small amount, the ease of bulk billing is such that you would see a dramatic drop-off in the number of patients by and large. Now, whether the amount of increase in fees is enough to compensate for that drop-off is another matter for practices. So fee-for-service works very well for acute care. Even with care plans and health assessments, it does not work well for chronic disease management, and nor does it encourage continuity of care. Trying to fix the problem by introducing ever more items is simple in theory, but very complex to manage or administer. Many practices can't even effectively and legitimately make best use of the care plan items or health assessments that are in place at the present time. This is a common thing that we're seeing with practices. We're simply underestimating what patients should be under these arrangements, and so we're not maximising the potential for income generation. So fee-for-service has its good points and it has its bad points. And the same with block grants. Block grants or other types of incentives are often based on a modified capitation arrangements, and we're all familiar with the capitation arrangements that applies in England. This is the case with the PIP, where there's modified arrangements in terms of standardised whole patients equivalents. Although with the PIP, there is a limit placed on a number of the items through the PIP that you can acquire and put caps on some of the payment arrangements. It's probably one of the bad things about the PIP. Block grants can be purpose-built for chronic disease management and continuity of care, and often have additional features associated with them, such as patient registration and practice licensing or registration. Now, the healthcare home model is or was way too complex. Practices found it difficult to navigate the administration, and patients weren't signing up to this in droves. Patient registration is moreover hampered by patient mobility. And whilst we all feel that our patients see us as the primary caregiver, often the case that they're actually seeing multiple practices, either because of work issues or just purely for convenience and choice. Now, this is complicated because of the open access to any practice under Medicare. I would argue that the current proposals around patient registration are too hard and need to be made simpler. They do not need to be hard, and they could be virtual. In other words, we don't necessarily, in my opinion, have to have a patient registered with a practice to get the benefits of patient registration in terms of chronic disease management. The second thing I'd like to say about block grants and structures is that inevitably under this arrangement, payments will need to reflect outcomes. In other words, the reward will have to come on the basis of outcomes at the end of the day. And this, of course, is one of the key factors about the fee-for-service, is that it's very, very difficult to measure the outcomes through a fee-for-service system. The third item that we wanted to discuss was in terms of co-payments or gap fees. Notwithstanding the difficulties I believe that are there, we should be revisiting patient co-payments or gap fees. A small fee from a patient per encounter would be far more significant than anything coming from a rebate increase. Many practices would be strongly in favour of the option of charging a limited co-payment in addition to bulk billing a service if this was allowed. But I stress that we fell down before because it was made compulsory and the market didn't get the opportunity to actually set the limit. There are ways to allow this co-payment arrangement with bulk billing where changes to the legislation are not required. But we should not underestimate both the legislative difficulties in the context of a bipolar political arrangement where one party, if you like, would be totally opposed to any allowing of co-payments for those areas. And one of the things just on the buy I'd like to say is that we know that a number of these cooperative practices are being established. It never ceases to amaze me how these cooperatives can actually charge a patient registration fee under the legislation while bulk billing all services. Perhaps it's a case of all animals are equal, but some are more equal than others. Now, there are other options which we don't have time to discuss here, but I'll happily take questions on them. Many, many years ago, as part of the reform process of general practice, the issue of budget or fund holding for pathology, prescribing and referrals was brought up. This was roundly condemned by the profession as being an attempt simply to ration these services. But I think it's something we can actually have another look at, just to see how we can build efficiencies into the system, and those GPs as gateholders into the system can get some benefits back. And there was another system that I've been looking at for a number of years. It's a virtual transaction system where a GP's intellectual property, such as patient details or medical history, can be on-sold into the health system. See, what happens at the moment, if you've got an electronic medical record system, is if you write out, using that system, a referral to a specialist or a referral for a prescription or a pathology report, there is considerable information that is readily taken up and easily taken up by those other providers. Now, effectively, if a GP is collecting that information, then there should be a vehicle by which they can on-sell that into the system because it's their personal intellectual property. The quality of the medical record that a GP takes is their intellectual property. And being able to incorporate that into an appropriate, for example, referral letter, I believe has a value to the system. And it's certainly got a value to the end provider. Because under electronic prescribing, for example, the pharmacy is saving a hell of a lot of money. So I believe we missed the boat with the implementation of IT when we should have been looking at transaction-based systems where a small payment came to a GP for the provision of that information because really it's their intellectual property. So in summary, I believe that our funding future options need to reflect appropriate patient care, support population health and chronic disease management, address outcomes, strengthen relationship between doctors and patients in a practice, and put some confidence back into general practice, which is sadly lacking. And again, I just was on a webinar last night when we're seeing the number of doctors that want to do general practice, continuing to slide. Now, slightly tangential, but I wanted to bring this up because the AMA has just announced their support for a sole employer model for GP registrars. I first raised this model over 10 years ago in my role as President of the Rural Doctors Association of Australia and on during discussions on a national rural generalist training program. What I saw then was with the increasing number of registrars coming on board, many practices were actually filling up. And there was a real risk, I believe, that GP registrars were not going to get the quality of exposure to clinical teaching that they should have. The other issue, of course, then, is that registrars have by and large increasingly become come from the overseas trained doctor bent. So the number of Australian trained graduates wanting to move into general practice has gone down. And where have they gone to? Because we've actually doubled the number of medical students coming through the system. Well, they've gone into the specialties, predominantly things like emergency medicine, anaesthetics, and those areas. So many of these doctors are actually providing primary care services under a different name. And so I asked the question at that time is what were the problems there? If you're looking at a national rural generalist pathway, or you want to provide flexibility for registrars, and you want to remove the administrative burdens for practices, my argument was there should be a sole employer model so that practices didn't have to go through the heartache of employing someone every 6 months or so, and the registrar could maintain flexibility and their work terms and conditions. So it occurred to me at the time that registrars and practices were at risk under the employment models, and particularly the fee-for-service percentage-based payment arrangements. I mean, how many of us have had to deal with registrars trying to negotiate higher and higher percentage-based arrangements? Well, of course, that wasn't accepted by registrars who wanted to get the benefits of what they saw of an open-ended remuneration system. And it was not accepted by some of the practices because they saw registrars as a workforce and income generation strategy. So the number of positions available for GP registrars has increased significantly over the years, but most of these positions are not being filled by Australian graduates, but overseas trained doctors. And most of those increase in positions have been due to the increased number of practices out there. So the driver in the demand for registrars now is really not patient need, but around our business models that we've established in general practices. So I think there are a number of benefits for registrars and practices. However, one of the things I think we might show is that under a sole employer model, particularly if it's something working under an award like some of the state awards, is that those registrars are actually going to be significantly better off, not only than their counterparts who are working under the current model, but also their supervisors, because there has been a dramatic increase right across the board over the years in the engagement arrangements and the industrial benefits for doctors working under the public health or other salaried positions. What are the downsides? Well, there are downsides, of course. Many practices would say if there's no incentive to see patients, then the registrar is not making us any money. And the downside for registrars is that if you are seeing a lot of patients, then you will make less money, but I think it will bring much more consistency. So I would welcome the AMA's support personally on a sole employer model, but again, I'd seek your input and feedback on this. So the bottom line today is let's think outside the box and not always through the prism of Medicare rebates. It's time for us to really come to grips with alternative funding arrangements for general practice that better reflects what we're trying to do and the modern challenges that we're facing in general practice. So again, let's not a good crisis go to waste, and let's all pull together, for the benefit of GPs. Okay, I'm quite happy to take any questions here now. You can enter those in through the system on the GoToWebinar. Okay, so we've got one from Jenny. Yeah, block grants are also difficult for contracted GPs in a medium-sized practice. You're absolutely correct there. And this is one of the pressures that's coming on, is that GPs working in practices under those contracts are saying, well, hang on a minute, I want part of these block grant arrangements. What I would argue is we have to rethink the way in which we actually engage our GPs and what the incentives are there for them. Some of the GPs simply want to come to work, but also pick up the block grant arrangements. And reality is that some of those things like the PIP form the only part of the profit for the practice. So I think we need to rethink how we actually structure that, so that if a doctor is engaging fully in those areas, then that means engaging at a practice level as well as just at a simple patient level. Then some of the benefits of this scheme, if you like, or model, would actually come through to those doctors as well. What are your thoughts about the planned introductions of the voluntary patient enrolment? Look, frankly, some of the discussions I've heard about this really scare me. I mean, it's too complex, and I don't believe that the benefits are actually there for practices or patients at this stage. And the notion that you can actually do a voluntary patient enrolment with an individual doctor rather than a practice, to me, is really just a nonsense. And so I think we've really got to rethink it and put a hold on some of the discussion that's coming out about that at the present time. So, yeah, I mean, I was opposed to the healthcare homes because I saw that as potentially having a direct impact on smaller practices. And no doubt there'll be commercial groups that will attempt to, wrap up the voluntary patient enrolment thing as well. What about nurse funding in general practice? MBS and fee-for-service places limits on the employment of nurses and the way in which they can benefit patient care, especially chronic care and preventative care. Caps on the WIP also affect practice funding. I agree fully. We had a practice nurse in our practice 37 years ago, before any of this P&IP and PIP stuff. I mean, we found them invaluable in terms of the management for patients. And we need to really start to address how we can actually fund those nurses and provide them with incentives in terms of this patient care that we want to seek. Nurses are very, very good at structuring up chronic care plans and those sort of things. They are very good at following those sort of guideline arrangements, and they provide an invaluable service. And I don't think that the current payment structures for practices or nurses actually reflects that at all. How would you implement a co-payment system in a majority bulk billing practice without a large loss in income or patients? Well, that depends really on whether the co-payment is brought about with a bulk billing system. In other words, that in some way legislation or governments or whatever would allow a small payment with a bulk billed service, because bulk billing is very, very convenient for patients. And even charging a small amount on top or moving away from bulk billing would mean that the practice would significantly suffer from a loss in income and patients, unless they charged significant fees and their patient population went right down. So it is a difficult situation, but I believe that for most practices, or for many practices, being able to charge on top of a bulk billed service a small amount would be a reasonable thing to happen. Now, at the moment, there are a couple of ways that this could be achieved legally, but legislation and politics would be one way. There are a couple of other ways which I won't discuss on the table here, but there are ways in which it can be done a little bit more simply, but it is difficult, and I guess then the market would actually set the scene. So if you're a practice that found you couldn't do that if it was allowed because the patients left or they didn't want to come in and pay $5 or $10 in addition to the bulk billed arrangement, then I guess as a practice, you have to start asking yourself about workforce and what you're actually providing for those patients in terms of the value. So the market would actually set the scene. Many practices I've talked to said that they want a co-payment, but they want it to be compulsory, so they don't have to make decisions. Well, I don't believe that's in the best interests of patients or practices ultimately. Okay, when patient co-payments were proposed years ago, was there ever a discussion or rejection of a non-compulsory payment, a patient co-payment? Many allied health professionals do this, even though I think not allowed. It works really well, though, for patients who don't have a lot in the bank at any time, but are prepared to pay something. Yeah, look, the discussion became totally politicised because the first time that a co-payment was raised was when I think Paul Keating was the treasurer and Bob Hawke was the prime minister at that time, and that was used as quite a significant political issue. And of course, you remember the last time it happened, there were a couple of attempts under Tony Abbott to actually do this, and it just went nowhere. And it went nowhere, I believe, because of the compulsion associated with it. And, you know, we had practices already putting up signs out at the front saying no co-payment here. So practices were already going to accept the drop in the rebate, which was associated with that co-payment being allowed, and they were going to accept that and continue to bulk bill. Judith, any suggestions about attracting GPs to rural areas, community organisations, Aboriginal mental health services becoming increasingly difficult? It certainly is, and I'm pleased to tell you a couple of things. First of all, we're going to do a webinar on workforce and look at some of the detail and depth around the workforce and why we are in a problem with medical workforce, even though Australia has more doctors per head of population than virtually every other developed country in the world. And we're also structuring up a podcast with one or two people who you'll be pleasantly surprised who have expertise in this workforce area. You know, fundamentally at the bottom of all this is a workforce problem that we have in Australia, and we need to address that as part of the reimagining of general practice. So sorry, I can't give you the final details here, but you know, we will be having that. Okay, right, well that looks fine. So as always, we appreciate your input. We value your feedback. We will send out the notes of this presentation, and we will send out a questionnaire through a WUFU questionnaire. So, you know, have your say, have your input. We will, when the coronavirus, you know, travel restrictions and things settle down, we'll be coming to a place near you to discuss some of these areas. We hope you found this useful today. As always, please send us your feedback and comments. Thank you very much.